Good morning, ladies and gentlemen. Buongiorno. I want to thank Professors Valuti and Volpi and Professor Perugia especially for the kind introduction and inviting me to participate in this event. And also to Professor Carlo Fabriciani for your kind invitation for me to be with this group of important professors in Italy to participate in this special symposium. I must first apologize for not being there in person as I'm in Hong Kong celebrating a very important family event. Today I would like to discuss with you some of the work in our laboratory on biological and mechanical augmentation on healing of ligaments and tendons. First, I'd like to acknowledge my co-authors, Dr. Speciale, Ms. Ferraro, Mr. Kim from the Musculoskeletal Research Center. Biological augmentation started in 1994 in our laboratory. We first used growth factors and cytokines, and then later we used cellular events, and eventually we gone to scaffolds. So for the last 10 years or so, we've been using scaffolds. Particularly, we look at extracellular matrix bioscaffolds that have the property of scaffolds as well as the cytokines. The particular ECM bioscaffold that we are using is the porcine small intestinal submucosa, or SIS. Even this scaffold is only 200 micrometers thick. It has non-homogeneous unique properties on the luminal side and the abluminal side. And first study we did was using 2 layers of this SIS ECM for healing the central third of patellar tendon defect used as autograft for ACL reconstruction. As you can see, when there's no treatment after 12 weeks, there's still a concavity in the healing patellar tendon, whereas with SIS treatment, we have fully filled the defects, and actually the cross-sectional area of the new tendon is 68% larger than the non-treatment. And when you test the tendon in uniaxial tension, we find that the structural property of the bone, neopatellar tendon bone complex, is increased about double, both in terms of its stiffness and ultimate load. So the message is from this study is that SIS can grow more tissues. And second study we did was using it to heal a deep gap, 6 millimeter gap of the medial collateral ligament. And after 12 to 26 weeks, we find that with SIS treatment, we get larger fibrils under transmission electron microscopy, whereas non-treatment, you get uniformly small fibrils. And that is because the collagen type 5:1 ratio is dropped and the diameter is bigger. With larger fibrils, we actually get better mechanical property of tissue. You can see the modulus, which is a measurement of quality of tissue, with the SIS group in blue is higher than the non-treated group, which is in magenta. So the message here is that SIS treatment can grow better tissues as well. So then the next we're thinking about is what about using ECM for ACL healing? And if ACL healing is successful, there are many advantages, including preserving the complex anatomy and function, both microscopically and macroscopically. And also the insertion site, the proprioception, and reduce the neuromuscular problem and so on. So we did a third study is used on ACL healing in goats. And before we do that, we did a couple improvements on these bioscaffolds. First, we used SIF from a genetically modified pigs to reduce immunological issues. Particularly, we eliminate the alpha-gal galactosidase epitope. You can see the wild type, there's a lot of alpha-gal, whereas the knockout pig, there's no green staining and no alpha-gal. And also, we make SIS into hydrogel form so that they can be injected to fill the wound site. And also, the growth factors in the SIS can actually make a lot more cells. Cell proliferation is higher, you can see on this panel, versus a plain collagen gel. And in terms of quantity, they are probably increased by about 25 to 30%. And also, collagen 1 production is increased with SIS treatment in the yellow bar versus the collagen gel in green bar. So with that, we go ahead and do an in vivo study. We first transect the ACL and repair with sutures. This is the control group. For the experimental group or SIS treatment group, we deliver a sheet of SIS with gel foam. We wrap around the wound site and then inject the hydrogel in the middle of the wound. So at 12 weeks, we can see this is a healed ACL with ECM hydrogel treatment versus the sham operated control. The continuity is restored. The hypertrophy is limited. There's no difference in the cross-sectional area. And histology showed that the fiber of the newly generated ACL has good alignment and spindle-shaped fibroblasts. And most excitingly, we find a layer of synovium newly formed to prevent the attack by synovial fluid. Then we look at the ACL function by using our robotic UFS testing system. And this is a system that can record the motion of the knee during passive flexion extension like you do in clinical exam to prove that we now cut everything away, all the soft tissues away in the knee, and we can do the exact same passive flexion extension motion as it were intact knee. And then we record all these data in three-dimensional motion at all flexion angles. You can see there's no connection in the knee, but we can move the knee just like an intact knee. And then we do external loading. Say we start from point A and we apply external load, go to point B, see how much the knee is moved, and then we will record it, and then we can do it without the ACL, we can do the healing ACL, etc. And the difference in terms of forces or motion are also recorded as the difference in AP translation and or in situ forces in the ACL. Now the results show that the green line, green dots are the intact knee, the sham operated control knee under 67 Newton of anterior posterior tibial lobe. And if we just do suture repair in magenta, you see there's a lot more AP translation. But with ECM treatment, we were able to reduce the AP translation. And actually, we've gone from 12 millimeters to 8 millimeters, but it's still higher than 4 millimeters of the intact knee. The in situ forces of the healing ACL were pretty close to the intact ACL, showing that it is functioning well. And then we dissect the knee into a femur ACL tibial complex and do uniaxial tensile testing, and we'll get a low elongation curve like the yellow line here. Of course, the slope is the stiffness, and then the ultimate load is recorded. And when we look at the data, we find the stiffness. This is the sham operated control in green, ECM treated, and suture repair. You can see that the ECM treated reached 48% of the control and is 2.2 times bigger than the magenta suture repair. And actually the result is comparable to ACL reconstruction from historical data. The ultimate load is about the same story. The ECM treatment is about 2.5 times that of suture repair and is comparable to ACL reconstruction. So the results, to summarize, that we, together with ECM bioscaffold and ECM hydrogel, we have synergistic effect of accelerated ACL healing, limited excessive cross-sectional area growth, better structural properties, better collagen alignment, and also a synovial protection of the neo ligament. So we want now to go into longer-term study, look at tissue remodeling, and see if we can achieve a functional ACL. Now, however, we also noticed that ACL healing is a very slow process, so we need some kind of mechanical augmentation using suture so that to load the ACL and help to maintain the joint stability. And we did an in vivo evaluation in goats, a 12-week study, by doing a mechanical suture augmentation as such, and then compared to simple suture repair. Again, we find that in terms of robotic testing, the suture augmentation in orange is about, in yellow, it has the AP translation about 25% lower than the suture repair alone. And in terms of augmentation, the stiffness is about 2.2 times higher. So showing there's some advantages in mechanical augmentation to improve knee stability as well as to aid the healing of the ACL. Our ongoing research now include longer-term studies, of course, looking into the mechanism, as well as areas of improvement of the scaffold to make the results even better. But one of the most exciting things we're doing is the brand new approach is using a biodegradable, bioresorbable metallic scaffolds made out of magnesium alloy. You can see that we make a ring out of magnesium, suture onto the transect the ACL, and helpfully to aid the knee stability as well as load the insertion sites. It bridges the gap between two ends of the ACL. It allows immediate uploading of the ACL to restore initial joint stability and prevent insertion site atrophy. Finally, magnesium alloy can be programmed to degrade over time and gradually shift the load to the healing ACL. And in a preliminary study, an in vitro study, robotic testing using a magnesium ring on the transect ACL, we find that this is the intact ACL in yellow. The ACL deficient knee, of course, the AP translation increased a lot. But with repair using magnesium ring, the AP tibial translation is reduced by approximately 40%. Also, the in situ force in the ACL reaches about 75–80% of the intact ACL, showing the function of the ring. So the message is that magnesium-based ring can help to restore the initial AP stability and loading the repair ACL at time zero. So our next step, of course, is to do in vivo animal studies. Basically, our thesis is that we know biological augmentation using ECM, scaffold, and hydrogel can help ACL healing. We also know the mechanical augmentation can also help in terms of stabilize the knee and their function and not to let the insertion site deteriorate. So our hope is to apply both and look at the synergy of both biological and mechanical augmentation in ACL healing. And we have done rabbits work, we have done goat work using functional tissue engineering, ECM SIS scaffold, and of course the next step we hope is to go to human, look at how you can apply in a torn ACL. And if there is success with this approach, then it would be an alternative treatment plan added to the surgeon's armamentarium or treating ACL injury. So with that, I want to say thank you very much and grazie mille. And I will be online from Hong Kong to join the discussion later in this session. I'd like to, at that time, you may ask me some questions or clarifications and also give me some comments of our presentation. Thank you very much.